during your internship, you will be going to different specialties, medicine, pediatrics, in and ops, and surgery. So now when you take those practices, you may be wondering now in the during the faculty days, you all learn community medicine or public health, and how we are going to put those knowledge and the other practical experience that you all got during your faculty days or the undergraduate period, how we are going to put into practice. Now, under today's program, we are actually trying to make you aware or make you knowledgeable about key communicable disease conditions, which are very, very important with regard to the disease condition status, as well as during your practice in the hospitals. Because controlling communicable diseases, as you all have learned, it is really, really important. So one of the major important areas in medicine is where if you don't control communicable diseases, what will happen is that the curative sector or the hospitals will not be able to handle the burden of those disease conditions which will be coming to the hospital. So it is very, very important that we control the disease conditions at the community. Now, when you are in the hospital, you will be seeing certain communicable disease conditions where the origin is at the community. So you will have to take, one thing is that identify the problem as well as take measures to control it. So take measures to control it means there are certain things that you can do it in the ward and certain things that you will be informing or notifying these conditions to the relevant authorities where they will be taking action. Now, after your internship, some of you all will be actually working as MOH, AMOHs in public health institution, as well as you may be going to PMCO, divisional hospital or somewhere where you will be then directly dealing with these conditions. So it's very important that you get that particular knowledge during your pre-intern as well as your internship period. Today's program, we have lined up so many important topics, and you will see that certain condition, disease condition, we have eliminated from Sri Lanka also. But we are at a risk of reintroduction of those disease conditions. So as intern medical officers, you have a huge role to and the responsibility to actually diagnose these conditions as well as to notify these conditions. You may see about this, the malaria condition, and for example, the leprosy. We have embarked on a huge campaign to detect the patients, because we will be we can easily eliminate that leprosy condition in Sri Lanka. So there are so many other disease conditions. Today's program, the lectures will be, or the discussion will be done by public health specialists who are expert in that particular subject area. So you will be getting the latest, current, updated knowledge with regard to this communicable disease condition. So it is therefore important that you participate in the entire program, because then you will understand that it is so important. You will never get a chance to get all the communicable disease related knowledge from one session. So you will be, today's session is very, very important. So we have lined up, got the experts, and they will be speaking to you, especially targeting your internship program as well as thereafter the practice in the healthcare institution and the community healthcare institution. So I won't take much time. We will start our program, and I hope that you will take the maximum out of this well-organized program and apply those knowledge during your internship or during your practice. Thank you.
Right. Thank you very much, sir, for that introduction and guidance for the program. So we started this pre-intern training program from 2015. So incorporating public health aspect to the pre-intern program is the first time we are doing. So we are very grateful and thankful for the DDG Public Health PHS1, Dr. S.M. Arnold. Thank you, sir, once again. So next up is lecture by Dr. Samantha Giganagate on immunization. Over to you, sir.
Good morning. Can you see my slides, please? Can you give me a feedback? Can you see the slides?
We can see it. You need to make it full screen.
Yeah. Okay. Right. Then good morning to you all. First of all, I would like to welcome on behalf of the epidemiology unit, all of you all pre-intern colleagues to the health system. During this brief half an hour, I will brief you about the current national immunization program and especially what we expect from you all from this program. Okay. When we talk about the immunization, because into the whole immunization program, what we expect is to be artificially induce the immunity, and that way we protect the particular index child for deadly diseases. That's what we call immunization. But all over the years, immunization has able to save billions of lives all over the world. But that's why there is a famous saying said, with the exception of safe water, no other modality, not even antibiotics, has had such a major effect on mortality reduction. Because there's no question about that. Out of the all public health strategies, if you can provide the safe water to the community, that is the best strategy. But other than that, next, immunization is the best option to prevent mortality and morbidity among children all over the world. The next, I think you all can hear me, no?
Yes,
Hello?
I can hear.
Yeah, sure. Okay. Slides also visible, I think. If any issue, please give me a feedback. Yeah. I think this is a brief introduction about our immunization program service delivery structure. You should have some idea, because immunization service delivery, our main objective of the immunization program is to have a country free of vaccine preventable diseases of public health important. That's our key slogan. But you all know our national immunization program is free of charge, and it is integrated into our primary healthcare delivery system, because certain countries have a separate immunization units, but in Sri Lanka is not such a separate immunization unit. We have that our immunization program, each level, starting from the national to bottom line at the MOH or divisional level, immunization program is integrated into primary healthcare delivery system since its inception. At the national level, you all know, the Ministry of Health level, immunization program is responsibilities hand over to the epidemiology unit. Then epidemiology unit is considered as a national focal point for immunization program. Because of that, epidemiology unit responsible for making policies, implementation, monitoring and evaluation, and provision of logistics for the national immunization program. In the next line is our provincial level. Provincial level, we have a provincial director of health services coordinate all the activities, that technical inputs given by provincial epidemiologist or provincial consultant community physician. Our next level is the district level. All district levels headed by administratively coordinate the program by a regional director of health services, technical coordination done by a regional epidemiologist. All 26 districts have one regional epidemiologist. Then at the bottom line, divisional level is our, we call MOH units. Altogether, we are having 358 MOH units. Those are the grassroots level service delivery points. You all know all these 358 units were headed by qualified medical officer or one or more based on the population. This MOH basically responsible for provision of all immunization services. But bottom level, public health midwife is the one have a direct link with the community. You know, each public health midwife have a around 3,000 populations, is accountable for the vaccination status of all children comes under care, because all the children she has to be registered in the birth and immunization register and follow their vaccination status. But you know, certain vaccines we are giving as a school vaccine, namely the ATD and the HPV. Those two vaccination, school vaccination is coordinated by the public health inspectors. But all our vaccination services done through a primary healthcare delivery system through a fixed clinic sessions. But in addition to that, all our major hospitals, starting from the teaching hospital base and district hospital and above, have a complementary immunization services available. Anyone can take services from either from primary healthcare delivery system or through a hospital. But when it comes to the immunization, I think as a country, we are having a very long history, because our first vaccination started in somewhere in 1886, more than 140 years ago, against the smallpox. That time there is an ordinance, compulsory vaccination against smallpox. That was the first vaccination, history of vaccination started in 1886 in this country. After that, time to time, new vaccines were introduced. But in 1949, BCG vaccine was introduced. 1961, triple vaccine. It means vaccination against diphtheria, whooping cough, and tetanus introduced. Then 1962, oral polio vaccine introduced. 1984, monovalent measles. 1996, rubella vaccine introduced. Then 2001, second opportunity for the measles contained vaccine in the form of measles and rubella MR vaccine introduced. Then 2003, hepatitis B vaccine. 2008, hip contained vaccine introduced as a pentavalent vaccine form, and 2009 live JE vaccine. 2011 both monovalent measles and MMR was replaced with the MMR, mumps, measles and rubella vaccine. Then 2015, you will know, we introduced the IPV, inactivated polio vaccine, because you know that's a global initiative, because now already, because earlier we used to, before 2016 we used trivalent oral polio vaccine. Trivalent means it contained all three types of polio virus, type 1, type 2 and the type 3. But globally now last case of type 2 reported in somewhere in 1999. Because of that, globally declared type 2 polio was eradicated. Based on that, because oral polio vaccine is a live vaccine, because of that live attenuated vaccine, that to sustain the elimination status, global decision taken to replace the trivalent oral polio vaccine with the bivalent. Because of that, currently after 2016, what the oral polio vaccine which currently we are using have only type 1 and type 3. Then to get the type 2 protection, the countries were requested to introduce the inactivated polio vaccine. That's why country introduced 2015 IPV vaccine. Then 2017, country introduced HPV vaccine. But up to now, country has our immunization program provided protections against 13 deadly childhood diseases. 13 deadly childhood diseases, starting from the TB. Actually, TB means especially the childhood TB. Then diphtheria, pertussis, tetanus, neonatal tetanus, poliomyelitis, Haemophilus influenza B, hepatitis B, measles, rubella, congenital rubella syndrome, mumps, Japanese encephalitis, and the HPV, that's again cervical cancer. Altogether, we are providing protection against 13 deadly diseases. This is our national immunization program. But I think all of this, throughout your career, you may be you're starting your career as a intern house officer, but after that you will climb in your ladder like a medical officer, SHO, maybe if you've done your postgraduate registrar, or sometimes you may, or senior registrar, even a consultant, whatever the field, or even you may, in meantime, you may practice as a general practitioner. But whatever the capacity you are practicing throughout your life, this is the mandatory, or whatever the capacity, or everyone has to follow this national immunization schedule. You can't deviate from national immunization schedule. That's the one thing I want to highlight here. Whatever the cap, you may be consultant, still if you are practicing medicine in this country, this is the minimum requirement. All of y'all has to adhere, 100% need to adhere to the national immunization schedule as a basic or primary requirement. But whatever the vaccine not in the immunization schedule, they can prescribe if the vaccines were registered in this country. That's a different thing. But when it comes to all the vaccines in our national immunization schedule, all practitioners, even not only in the government sector, even in their private sector, everyone has to adhere to those vaccines as well as the timeline. You can't deviate from these timelines in the national immunization program, the national immunization schedule, because this national immunization schedule is the recommendation of the advisory committee on communicable disease. That's the governing body when you take in the policy decision regarding immunization or control of communicable diseases. That committee was chaired by Director General of Health Services. That committee, our current national immunization schedule is the latest one endorsed by National Advisory Committee on Communicable Diseases. Because of that, throughout until the advisory committee make any changes to the schedule, everyone is supposed to, even your GP practice, you are supposed to 100% adhere to this national immunization schedule as a basic requirement. According to that, our national immunization schedule, all of you all are supposed to give the BCG vaccine, preferably within the 24 hours of birth. That's why, as a country, you all know, once you may attach to pediatric wards or Genanobs ward, please make sure before discharging child, you have to make sure child was vaccinated against BCG. Because usually, preferably, if a healthy child, within 24 hours, we expect child to be vaccinated with BCG. If you have any illness or any other thing, sometimes you may have to prolong their vaccination status, but you have to make sure, unless there is a specific contraindication, you have to make sure child is vaccinated. If child is fit to go home, child need to be vaccinated against BCG. Then at birth, then again, in the completion of the 2 months, they will have to give the oral polio vaccine first dose and the pentavalent vaccine first dose. Pentavalent vaccine covered 5 diseases, diphtheria, protection against 5 diseases, diphtheria, tetanus, pertussis, hepatitis B, and Haemophilus influenza, first dose, and the fractional dose of IPV, because that's I explained what's the rationale of introducing inactivated polio vaccine, but which we are using the fractional dose. Fractional dose means the intradermal dose we are giving. Another message, please, when you are working, especially in the pediatric wards and the Genanobs ward, please have a look on postnatal side, the giving the BCG, because the BCG vaccine we have to give as an intradermal mode. But it's very important to that particular vaccine need to be given as an intradermal vaccine. Some instances we have seen is not given as an intradermal. That mode is very important. Whatever the vaccine, certain vaccines intradermal, certain vaccines IM, some vaccines we recommended deep subcutaneous, but that particular plane is very important, because based on that particular plane, absorption rate will be is changed, but at that particular vaccines is produced that need that particular mode of absorption. That's why, especially with the BCG, please have a look that when they're administering the BCG vaccine, they are following the proper intradermal technique. Otherwise, sometimes if we give the BCG vaccine to the deep play, like subcutaneous or deep subcutaneous, there is a possibility child will develop BCG lymphadenitis, because the BCG is a live vaccine. Then sometimes child may end up with the massive BCG lymphadenitis, means you have to do the IND and 6 months treatment with the anti-TB drugs. It's a crime. Because of that, sometimes if you give the BCG vaccine to the wrong plane, that sort of things can happen. Because of that, please make sure have a look on that and supervise BCG vaccination activities at your postnatal site. Then on completion of the 4 months, we are giving the second dose of oral polio, pentavalent, and the fractional IPV. Then completion of the 6 months, we are giving oral polio, pentavalent vaccine, and the third dose. Then completion of the 9 months, we are giving a first dose of MMR vaccine that cover measles, mumps, and rubella. Then that's the first year of life. Then second year of life, we are giving completion of the 12 months, we are giving live JE vaccine. Then completion of 18 months, we are giving oral polio and DPT vaccine, fourth dose. At the preschool age, it means completion of the 3 years of age, we are giving MMR second dose, mumps, measles, and rubella second dose. At the school going age, at the completion of the 5 years, we are giving oral polio and DT. And the completion of the 10 years, we are giving, it means grade 6. We are giving first dose of HPV only for the female students because our main target is to prevent cervical cancer. And after 6 months gap of the first dose, we are giving the HPV second dose. Then grade 7, it means completion of the 11 years, we are giving ATD vaccine. That's called adult tetanus and diphtheria vaccine. That's not equal to the DT vaccine, which we are giving at the completion of the 5 years. That's why it's always simple A, capital T, simple D, because dosage of diphtheria concentration is low because of to make a low immunogenicity. Then in addition, you have to make sure if you are working as a MOH and all females now coming into the delivery need to be protected against both tetanus and the rubella. But rubella is a live vaccine. You can't give rubella vaccination once mother get pregnant. Because of that, or if you are working, if you happen to work as a MOH in the future, you have to make sure in your area all the mothers before they become pregnant, all of them should be protected against rubella vaccination. That's why we call reproductive age females 15 to 44 years need to be protected, because nowadays I think all the mothers, because of the rubella protection, we considered if a mother has received during her lifetime one rubella containing vaccine, we considered as that mother is protected against rubella, because major objective of giving rubella vaccination is we want to make sure to prevent congenital rubella syndrome. It's a incurable condition. Child might, if mother get the rubella infection during the pregnancy, child might end up with there's a possibility end up with the chronic rubella syndrome. Chronic rubella syndrome means sometimes that's as a result of chronic rubella syndrome, child may be a mental retarded, sometimes severe congenital heart disease, sometimes maybe blind, sometimes deaf, or sometimes end up with the combination of whatever the symptom be. But 100% curable condition. But we are proud to say, because of our vaccination program, last congenital rubella syndrome baby born in this country 2015. After 2015, not a single child born in this country with congenital rubella syndrome. But challenge is we have to sustain that. We have to make sure all pregnant mothers before they become pregnant were protected against rubella containing vaccine. Other thing is the tetanus toxoid, because that's the main objective of giving tetanus toxoid to the pregnant mothers is to protect neonates from the neonatal tetanus, because it's a real killer in the earlier days. In the 1960s in Sri Lanka, I will show you the graph, that roughly 1,000 children died during the 4th day of their life due to neonatal tetanus. Out of total birth cohort in 1960s, can you imagine 1,000 newborns died during the first 4 days of their life due to neonatal tetanus. But we started 1962 our tetanus vaccination against pregnant mothers, but last neonatal tetanus case reported in this country 2009. That was in the Boton area in the Batiklo uncleared area. But in nearly last 12 years, not a single neonatal tetanus death reported in this Sri Lanka. But challenge is we have to sustain this achievement. For that, we have to vaccinate all pregnant mothers according to this schedule. Because according to this schedule means usually the first pregnancy, we expect mother to give the 2 tetanus toxoid doses. Completion of the 12 weeks, we are giving the first dose, and after 6 to 8 weeks, we are giving the second dose. But subsequent 3 pregnancies, in the second pregnancy, we are giving the 1 dose, third pregnancy, we are giving 1 dose, and the 4th pregnancy, we are giving 1 dose. It means if the mother received after four pregnancies, she has already received 5 tetanus contained vaccines during pregnancy. Then subsequent pregnancy, it means 5th pregnancy onwards, she do not need to get the tetanus toxoid, because once they received 5 doses, we consider she is protected for her life. I think it's clear. First pregnancy, 2 doses of tetanus toxoid. Subsequent 3 pregnancies, 1 each. Then altogether 5 in each. If she become pregnant more, the 5th time or 6th time, no need to give tetanus toxoid. But that's for the child, pregnant mother without any documented evidence of childhood tetanus toxoid vaccination. But nowadays, most of the pregnant mothers, they have their documented evidence. So it means they are CHDR. If we have their CHDR, means usually according to our national schedule, at the age of 12 years, every child should receive minimum of 6 doses of tetanus contained vaccine. 3 months, 2 months, 4 months, 6 months, 18 months, 5 years, and the grade 7. But if we have a documented evidence that mother has, at the time of once she get pregnant, she has received 6 doses during her childhood with documented evidence, that but if the pregnancy happened during the within the 10 years of last dose of tetanus toxoid, last dose of tetanus toxoid means we are giving grade 7, it means 12 years of age. If she become pregnant, say 20 years of age, within 10 years of last dose, then that particular pregnancy do not need to give the tetanus toxoid. But if it is go beyond 10 years, she need only single dose. All those informations are very clearly follow those things. But sometimes, that's why I specifically mentioned, sometimes some individuals are now having try to make some practice. That's totally wrong, because you have to identify that tetanus bacteria is everywhere. Because of that, you can't say you are doing the private places are 100% sterile, no need. No, whatever the place, all pregnant mothers, according to national schedule, need to receive tetanus toxoid according to this schedule. This, I think, is very clear. I think I am not going to detail about that. That's the importance of that's a concept of herd immunity. You know, these blue chaps are representing the unvaccinated healthy fellows. But if you red chaps are the infected person, if the infected 2 people come into the unvaccinated crowd, I think they can convert all fellows into the unvaccinated status, because there is no immunity in the community. But if you partially vaccinated, the yellow ones are the ones with partially vaccinated ones. Even if the few partially vaccinated, still if the 2 people come, even a few, 2 means if the few people comes with infection, they can spread the disease to the community. But if the other way, if the large number of over 95% of vaccinations were done in that community, it means all are in most of them were in the yellow category. Even if the red people, infected people comes, they can't transmit the disease as expected. Even among them, there may be a few unvaccinated children. They also get protected. This concept we call, I think you have learned this in your microbiology, herd immunity. That's why the whole purpose of immunization is to create the herd immunity within the community. These are our national vaccination program achievements. The last case of poliomyelitis reported in this country, Sri Lanka, 1993. Even I haven't seen the polio case as a clinical case. Last case reported in LRH in 1993. But last case of diphtheria reported in 1991. I think none of us have seen the diphtheria, clinically diphtheria case. Last case reported in 1991. Then measles country was eliminated because last endogenous case earlier reported in 2016. But unfortunately, you know, because I will come to that, because of the full few fundamentalists with their vaccine refusals, few cases were reported during last few months. But still, it's very much under control because majority of the community was vaccinated. Then last case of smallpox reported in Sri Lanka 1972, but global eradication declared in 1979. You can see how maturity of our immunization program. Then our congenital rubella syndrome, Because usually before introduction of the rubella vaccine, country has experienced nearly 250 to 300 congenital rubella children per year documented. But country has achieved last case of congenital rubella syndrome reported in this country 2015, and country get the elimination of rubella in 2020. Neonatal tetanus also last case reported in 2009, and the elimination declared in 2016. Then other than that, the Japanese encephalitis, whooping cough, hepatitis B, Hib, all those diseases are no more major public health problems in this country, because recently the country has done the national level survey and found among less than 5-year-old children, and found our hepatitis B incident among less than 5-year children is 0. And pregnant mothers hepatitis B also 0. I think those are the achievements of national immunization program. But now it's a challenge is, though we are very proudly say we have achieved that, but how we have achieved that, that's I think we have to keep in mind in the future. Doctors, when you are practicing, don't get the wrong idea. Now those diseases are no more, that's true. But how we keep it, those diseases are no more in our community, thanks to national immunization program. Because other than the smallpox, human beings were not able to eliminate none of these viruses or bacteria. Only smallpox, now no need to vaccinate, because globally smallpox virus is eradicated from this whole globe. Because of that, no need to further vaccination. But other than the smallpox, all the other diseases, polio, diphtheria, measles, tetanus, rubella, all these viruses and bacteria are happily roaming in our communities. Bacteria, viruses are there, but how we are maintaining the 0? Thanks to very high, near 100% vaccination coverage we are maintaining over the decades. That's why you can't relax our vaccination strategies. It's like we are keeping a rubber ball inside the water basket, because if you release the pressure, ball will come up. That's why, because of that, don't get the wrong idea. No, last case of neonatal tetanus reported in the 2009. Now we can stop the pregnant mothers' tetanus toxoid vaccination. No, you can't do. Even if you do that, within few months, cases of neonatal tetanus will appear, because you know tetanus bacteria is everywhere. Because of that, don't get the wrong idea. All those achievements we have achieved with the high sustainable, high quality vaccination coverage. If we, even those viruses and bacteria are there, because even if the slightest deviation in our reduction in our coverage, those diseases will appear. Because of that's our responsibility, because the country has achieved those things through a hard work of our predecessors over the 3-4 decades. But we can vanish everything within weeks, within few months, if we are not sustain our high quality vaccination coverage. Because of that, all of us have a mandate or responsibility to protect these achievements we achieve through this vaccination program. To give some insight about that, because you all have not seen most of the diseases. Even I have not seen those diseases. I will give some insight, because you can see these are the 4 graphs. First graph indicate the incidence of poliomyelitis in the red bars, but those are incidents per 100,000, not the absolute numbers. Cases per 100,000. So certain years, 1965, we have massive outbreak, 18 per 100,000. But it means if you 100,000 population, then you can imagine what's the total absolute numbers, because outbreak proportion 1960s, every other year country has experienced the measles outbreak, polio outbreak. But most of the certain people have died due to respiratory failure. But even today we can see certain people who survive with the permanent disability. But those are the people lucky enough to survive. But hundreds of people have died due to polio. But now you haven't seen the case, but because of the high vaccination coverage. Green line show the vaccination coverage. You can see when vaccination coverage increase, red bars diminish. But now we are maintaining the 0 red bars for nearly 25 years, thanks to this high vaccination coverage. Even if our vaccination coverage drops today, next few years, I think again these red bars will appear. That's a lesson we can give. Then I think it's a neonatal tetanus. As I mentioned earlier, these are red bars indicated the rate per the population, because some years, 1960s, we're having a 250 per 100,000 population. Then you can see, because it's a deadly condition, because the neonatal tetanus. But we have a data, epidemic have a data from 1950 onwards, most of the diseases. But you can see when we started 1960s green line vaccination against pregnant mothers against tetanus, how neonatal tetanus has diminished. We are maintaining the 0 since 2009. But we have to maintain this green line at 100% level. If it is dropped, these red bars will reappear. Whooping cough also same. Diphtheria also same. Diphtheria, none of us have seen the cases, but it's a deadly disease in 1960s. But diphtheria outbreaks are happening in our surrounding countries, India, Nepal, Bangladesh. The diphtheria outbreaks are very common, but we are protecting our yard because of the high vaccination coverage. Then it's our duty to protect our vaccination coverage. If our vaccination coverage drops, definitely these diseases will appear very soon. Then same thing with the measles. Then same thing with the other thing is the general tetanus, because you can see, I'm not talking here in the second slide, second graph, not about the neonatal tetanus, general tetanus among the community. Because now large proportion of the people are, because all the children are getting protection, more than 5 doses of tetanus toxoid. It gives some form of a protection to whole life. Then pregnant mothers getting protection during their pregnancy. As a result, what happened is now, earlier tetanus is a deadly disease in the community among adults, but nowadays had come to near 0. Now 10 or 15 cases of tetanus reporting for the whole year as a result of good vaccination coverage. Then rubella also, you can see 0 we are maintaining. Japanese encephalitis, another deadly disease. We can see earlier we have a massive outbreaks in 1980s, 85, but with vaccination, now caseload has come very low, even less than 20 cases reporting annually now. Those cases also not among vaccinated children, among the adults who are not vaccinated. But now to a main challenge, as I mentioned earlier, is to how to sustain this vaccination state, how to sustain the achievements we have achieved. One thing is the minimum requirement is to maintain the high immunization coverage. No choice about that. Our ceiling level is 100% coverage. Without that, even 99.9, we can't achieve that. We have to maintain high immunization coverage. But just having immunization coverage won't serve the purpose. Sometimes you can vaccinate all the children, but if you are not the quality vaccinated, but we have to vaccinate it with the high quality immunization services. If your vaccine vials were exposed to the high temperature or freezing temperature, no point of just vaccination. Those are inactivated vaccines we are giving. Or what happens is a vaccine which are intended to give in the intramuscular, if you administer the deep subcutaneous, no point, you can't get the desired result. Instead of giving the 0.5, if you give the 0.4, then no point of the acute immunity, required immunity. That's why maintain the high quality as a medical officers, future MOHs, or even in your ward setting, you're supposed to observe those quality of vaccine, maintaining the cold chain and other things we have to observe. Another thing is the age appropriately we have to give. Sometimes you can give the 100% vaccination, high quality, but still if you are not giving it the appropriate age, then during that delay, child might get the disease. Because of that, all three factors, it's very important. Then other than that, some quality issues, I think you have to get some idea, because sometimes even as a medical officer, you will have some wrong ideas because because you know, our government the program is providing all the vaccines free of charge, high quality vaccines free of charge. But sometimes because of we are providing free of charge, we don't have much of value on that. But I think that's not the truth. All of medical officers, you should know the truth, because all vaccines used in our national immunization programs are WHO pre-qualified product. What do you mean by WHO pre-qualified product? Because when you know, with any piece of soap or toothpaste, we assess the assessment based on the SLS logo. like that, when it comes to the vaccine, that particular logo assurance is the WHO pre-qualified product. All the vaccines used in countries are, even all registered products are not WHO pre-qualified product. WHO pre-qualified means WHO always give the assurance about the quality and safety of that particular product. Usually WHO pre-qualified product have a higher price in the world market compared to the non-pre-qualified product. But in our national immunization, using all vaccines are, that's a mandatory requirement, WHO pre-qualified product. Because of that, there is no issues about the quality of the product, though we are providing free of charge. Other thing is in the administration, in our national immunization program, we always use the auto-disable syringes. Auto-disable syringes mean there is we can assure that no possibility of reuse in the vaccine, because automatically syringe get locked up once we use it. But even private sector not using the auto-disable syringes. Other thing is all our vaccines because nationally we are sorting vaccine at the epidemiology unit, walking call room, like large rooms. All district have one walking call room each. All those vaccines temperature were round the clock monitored through a global monitoring mechanism. Even a slightest deviation in the temperature, they inform us we are taking measures. Because of that, we can give assurance about the cold chain of the national immunization program round the clock. Berlinger Institute in Denmark, Copenhagen, they monitored our major cold vaccine storage facilities. In addition, all our MOH officers have a backup power supply. All our RMSDs have a backup power supply. And the other thing is that we are using all our MOH officers were provided with the special refrigerators we call ice line refrigerators. I think none of these private sector institutions have ice line refrigerators, because ice line refrigerators are made only for the storage of vaccines. Because even if the power failure, vaccines can protect nearly 24 hours without any hassle, because that temperature, because that particular ice line refrigerators are designed in such a way. But most of the places we can see some private places, they store vaccines in the domestic refrigeration. But domestic refrigerators are not meant for vaccine storage. Because of that, it's very important to have our all 358 and all hospitals have a ice line refrigerator. Then all refrigerators have this fridge tag. Fridge tag means automatically every 3 seconds monitor the temperature. Because of that, any deviation in the temperature, we can take necessary measure. All 358 MOH areas have a ice line refrigerate, mean electronically monitored temperature round the clock. Then I think what last slide is what we expect from the medical officer as you. When you are practicing, you may be practice as an intern house officer, medical officer, SHO, general practitioner, or registrar, senior registrar, or even consultant in future. But always make it your prime duty and prime responsibility to always cross-check the immunization status of children with their CHTR. Child might come for any other ailment. Always ask for the CHTR and cross-check their vaccination status, whether they were vaccinated or not. Any deviation of vaccination, if you have seen, is immediately refer them for and try your best to complete their in the hospital setting. Child might be admitted to any other disease in the pediatric wards. But if the child's vaccination status is not done, if a child is fit enough to give the vaccine at the discharge, you can complete their vaccination and send back or refer to the MOI. That's your prime duty. Then if you find where the vaccine refusals, in the Sri Lanka, now it's an emerging issue, very small minority of fundamentalists, they refuse vaccine without any reason. But please explain to them the consequences. If they are refusing, they don't know the value of the fatal consequences of those diseases. That's why they have a assurance, they know this is no more happening. Because these actuarial things we will provide you all in future with what are the possible consequences if your child get polio, if your child get neonatal tetanus, if your child get diphtheria. These are 100% preventable, but if your child are at risk if you are not vaccinated, please explain to them. Other thing is, if you find child with any severe or fatal illness following immunization, that can happen, especially with the pediatric wards, child might admitted after vaccination, certain things can happen. But remember, all the events occurred after vaccination are not due to vaccine. Because of that, when you're communicating with the parents, you have to be very careful. Sometimes, because of our irresponsible statements made by some of our colleagues, creating a lot of problems, because first instances don't come out with the thing saying this may be due to vaccine. Because how can you say? Because you know, because a certain number of children are dying due to various other reasons. That's why, you know, even all countries have an infant mortality rate. So certain countries have luckily Sri Lanka have say 8 infant. It means out of 1,000 children born in this country, 8 will not survive to celebrate their first birthday, but they are not dying due to vaccine. They die due to different other illnesses or congenital abnormalities or other issues. But first year of life, we are giving 6 antigens vaccines. But it means every 2 months we are giving 1 vaccine. During that time, there may be a synchronized the time the particular death with the vaccination after. But because of that, until you have a complete post-mortem and there is a mechanism in the country, if any death happen after vaccination, we have a comprehensive investigation and assessed by an individual expert group is there. We call causality assessment. Until we complete that causality assessment, we can't come to the judgment that particular death is due to a vaccine. Because of that, when we are communicating with the parents, we are mindful, be responsible, because first, until none can say by looking at this is due to vaccine, but we have to investigate, and with proper scientific evidence only we can spell out. Because of that, be mindful as a medical officer in future or to your career. All those informations are available in our website. You can, if you need to read, get the idea, immunization handbook, give an extensive idea about these things, and the national, all textbooks and things are available. Thank you.
Right. Thank you very much, sir, for the detailed lecture on immunization. So, if you have any questions, you can use the chat box to ask questions. So, at the meantime, we will move on to the next lecture by Dr. Chintra Pereira, consultant community physician at Epidemiology Unit on the topic of communicable diseases, surveillance and disease notification. Right. Over to you, man.
Hello, good morning, everybody. I'm Dr. Chintana from the Epidemiology Unit. Can you hear me clearly?
Yes, we can see your slides. Can you move one slide and see?
Is it visible, the slides?
Yeah.
All right, okay. I'll start from here. So, my topic is interns' role in communicable disease notification. Right. So this is a very important part in disease surveillance and control activities, because that has to be start from the notification part. Right. Right. So what is disease surveillance? This notification, the concept is surveillance. The purpose why we are doing this notification is it's a part of a surveillance system. So what is this disease surveillance? Disease surveillance is it's a continuous collection, analysis, interpretation, and dissemination of systematically collected data on communicable diseases for use in public health action to reduce morbidity and mortality and to improve health. So this is a surveillance is a continuous collection. It is not a one-time process. So we are not going to stop at the time by collecting the data, but we do analysis, interpretation, and we do the dissemination also. So most important integral part of this surveillance is action. So always the data we collect, it should be connected with action to improve public health, to reduce the morbidity and mortality. So this surveillance system, the Sri Lankan disease notification system, surveillance system, starts from the hospital. So the first point of data entries from the hospital. So when they enter the data, that will go to the MOH office, then to the PHI, and again to the epidemiology unit, then epidemiology to the feedback. So the hospital, the medical officers, the intern officers, they are doing a very important part in this our communicable disease notification or this surveillance system, right? So communicable disease surveillance system in Sri Lanka, this provides us the basis for control and prevention of communicable disease. This provides the basis. So why we say that this provides the basis is, so from this information, we get to know the disease epidemiology of the country. What are the diseases we have? What are the patients come for hospital treatment? So it provides the basis for control and prevention of communicable diseases. The main objective of disease notification system is prevention and control of spread of communicable disease in the country. The main objective is prevention. Communicable disease notification, this is a legal requirement of the country. Any doctor who come across with any patient appear in the notifiable list should have to be notified. The Quarantine and Prevention of Disease Ordinance that was enacted in year 1897. That was a very old act. So it has provided the legal provision for notification, right? So there is a legal provision as well. According to the Quarantine and Prevention of Disease Ordinance, every medical practitioner or person professing to treat diseases who attends on any person suffering from any disease in the list shall notify to the proper authority. Any person who contravenes this regulation shall be guilty of an offense, and such person shall be prosecuted in a magistrate court. So legally, any person who treats for a patient with a notifiable disease has to be notified. That doctor is legally bound for this notification. So, right? So every medical practitioner, so anybody like both government and private sector, both inward and OPD doctors, all categories of medical officers, interns, MO, SHO, registrar, senior registrar, consultant, GP, MOPD. So anybody. So you all are as interns when you are treating the patients, when you are taking the history of the patient. So if you come across with any patient with a notifiable disease, you have to notify. So notify by one doctor is enough. So in your hospital, if there are patients with notifiable disease, if you notify, that is enough. You don't need to notify by many treating doctors, right? For one patient, one notification is enough. So to whom you have to notify? You have to notify to the proper authority. So who is the proper authority? Medical Officer of Health, MOH, of a patient's area of residence. By now, you may know that Sri Lanka divided into about 358 MOH areas, Medical Officer of Health areas. They all are MBBS doctors. In addition to medical officer, there are additional medical officers as well in this MOH area. So when you find a patient with a notifiable disease, you have to notify to that proper authority, that relevant MOH area you have to notify. And also for some selected diseases, in addition to MOH, immediately you have to notify to the DGC, DDG, PHS sponsor, or Chief Epidemiologist or Regional Epidemiologist. Those are the first group of diseases like cholera, plague, yellow fever. But usually nowadays you don't get these diseases. So you don't have to worry about this part much, but the first part, the other diseases, you have to be very vigilant on notifying to the relevant MOH office. So we'll discuss this in detail. So this part is very important. Notification should be done based on suspicion, because the purpose of our notification is prevention of spread of the disease. So you have to notify based on suspicion. As an example, we'll take if you find a patient with a fever, with body aches, and you suspect that this patient is having dengue, but you don't have any confirmatory test. You may have not done it, the full blood count test sequence, full blood count test, NS1 test, you have, that's all right. But if you suspect that the patient is having dengue, please write that notification form. I'll show you that H544 form and notify to the relevant MOH office. That's all right. Your diagnosis may be incorrect. After about 2-3 days, you may get to know that the patient was not having dengue, but leptospirosis. That's all right. Because you will not do any harm by notifying on suspicions, right? You will not be penalized, that's for sure, because the purpose is prevention, right? So when you notify the MOH office, the PHI, the area PHI, he will go and do some kind of a preventive measure. So that is a bonus for the country because somehow that will prevent some kind of a spread of the disease. Because of that, please don't wait until you get the confirmation of a disease. You don't need to wait until such time. On suspicion, you notify, right? As early as possible, not at the time of discharge. Please don't wait until the patient is discharged to notify, because usually dengue patient or leprosy patient, he may stay in the hospital about 2 weeks. So after 2 weeks, when you notify, that will not do any good, because by that time, all the spread have already done. So that will not do very significant type of prevention to the public at the field level. Because of that, that's why we are saying that please notify on suspicion. Don't wait until the time of discharge. Right? So this is the list of notifiable diseases in Sri Lanka. You can see there are 29 diseases. The first group, cholera, plague, yellow fever. You don't find these diseases now, but if you come across anyone, please, if you suspect them, please give a call to DGC, DDG, PHS1, Chief Epidemiologist, RO, MOH. So you can notify to the MOH or the regional epidemiologists in the regional epidemiology unit in each and every district. So these are the other diseases: AFP, poliomyelitis, chickenpox, dengue, diphtheria, dysentery, encephalitis, rubella, enteric fever, food poisoning, human rabies, leptomalaria, measles, meningitis. So these are the list of diseases. So when you are treating, if you suspect any of these cases, what you have to do is fill this form, H544. It's available at each and every ward. So back of that form, it shows the list of these communicable diseases. The front, it's a small paper. In front side, it shows the information you have to fill before you to notify. The back side, it shows this list of diseases. So you don't have to worry. When you go to the ward, please check that H544. Back of that, it gives a list of diseases. If you can't remember, if you are not sure, please refer that and you can check the list of notifiable diseases that you are supposed to notify, right? And there's another important one, simple continuous fever more than 7 days. There are patients with fever with more than 7 days without any diagnosis, please notify. Please notify. And also any other disease occurring in epidemic proportion. That's part also very important. Epidemic means there are different types of definitions for epidemic. So you see that in your ward, if you get like, if you take example in skin diseases, many patients from the same area in a type of a skin. So that is a significant thing because you are getting patients from a particular area. So that is type of outbreak. Then please notify that type of diseases also to that relevant MOH office, right? So to be more specific, we have introduced disease surveillance case definition. So these are not the diagnostic purposes for your clinical purposes. We have published a case definition book. This is available at the epidemiology unit website. So if you want to be more specific, so these are the diseases you are supposed to notify. Each and every disease, we have given case definition for that. So if you have this 1 or 2, 3 or 4 symptoms and signs, so you can take that patient as a disease A or disease B like that. So we have introduced this to keep the similarity between all the cases notified by each and every hospital. So if you want to be more specific, please refer this book. PDF book is available in our website. Then you can notify the patient according to this case definitions. Right? So this is the most important form. You have to be familiar. This is H544. This is the form you are supposed to fill. So if you can concentrate mainly on this form, that will be very much enough, right? So what you have to fill is, so now imagine that you find a patient, you suspect leptospirosis. Right? Can you hear me? Are you with me? Can you hear me? Hello?
Yes, sir.
All right, okay, right. So this is the most important form. You have to be very familiar. So this is H544, right? So if you come across the patient, you are suspecting that the patient is having leptospirosis. So that is a case that you have to notify, right? Then you have to fill the institution, your hospital, the disease, leptospirosis, name of the patient, date of onset from the history, pediatric patient, a guardian's name, date of admission, BHT number, ward, age, sex, lab results. This is most important part, home address of the patients. So this one, please don't take the home address from the admission book, because usually when the patients are get admitted, they give a nearby hospital. If they have any relative close to that hospital, they give that relative's address. So that is not the address you are supposed to notify, because our purpose is prevent further spread. So this the patient is from somewhere else, like Nigambu, and the patient get admitted to the Gampa hospital, and if they give a on admission address close to Gampa hospital, but you have to notify this patient to the Nigambu, that patient residential area address. So that is the place where this patient got this leptospirosis or dengue, right? So please be careful, and please get the address from the patient. Please, when you are taking the history, please fill this form as well, right? But please don't take the address from the admission registry. That may be not incorrect, right? And the contact number of the patient, signature of the notifier, your signature and your name, your status, HO, and the address and the date. And here, address of the MOH area, Gampa, MOH area, Nigambu, somewhere. So you have to identify the MOH area according to the patient's address. So if you are not sure, the list is available with the ICN, Infectious Control Nursing Officer of the hospital. There are only 354 MOH area. So according to the address, you can get the relevant address of the MOH area from your Infectious Control Nursing Officer. In each and every hospital, there is a unit called Infectious Control Unit, right? There is a nursing officer, 1 or 2 nursing officers. We call her Infectious Control Nursing Officer. So she has all this information. If you're not sure about the MOH area, you can get the details of the address of the MOH area from the ICN, miss, right? Okay. So this is the data flow, right? Now you are here. I think you can see my cursor. These are the that major diseases, cholera, plague, yellow fever. By telephone, you have to inform to DG, sir, DDG, PHS, answer, REO, Chief Epidemiologist. So this is the pathway we are supposed to go from here, BHT. Now you fill the H5444, right? Then after filling that, you have to, the nursing officer will fill, there is a notification register in the ward, the ward notification register. And after completing the ward notification register, that H544 form will be sent to the ICN office, which I mentioned in your hospital. The ICN office, that is not your part. Your part is to fill the H544 form, right? So this is how the data flow occurs. From the ICN, she has another form that has another register, that is institutional notification register. In your ward also, you have ward notification register. So each and every ward, you have ward notification register. So that includes all the notifications done by that ward. From that, after filling the ward notification register, that H5444, which filled by you, will be sent to the ICN, miss, Infectious Control Nursing Officer in your hospital. So she will fill her notification register. So that notification register includes all the details of all the patients of your hospital notified, right? Then after that, she will post that H544 form to the relevant MOH area. From the MOH area, Medical Officer of Health area, I think you can see this cursor. So they have another notification register in the MOH office. So staff will fill that notification register according to the H544 form they receive. That is the form you fill. So they will fill that notification register, and from the MOH office, SPHI will hand over that H544 form to the area PHI. One MOH area is divided into 4, 5, or 6 PHI areas. So that H544 form filled by you will be handed over to the area PHI from the MOH. Then the PHI is supposed to go and investigate the case and confirm the case and return back with another form. We call it H41151 form after investigation. So the investigated cases will be entered in a ID register. That is a special thing, not relevant for you for the MOH office. All the confirmed cases will be entered in the ID register, and from the MOH office, each and every MOH office from 358 MOH officers, they are supposed to send a weekly return to the epidemiology unit. So by Friday, we will get information of all the cases of the country. So that remember that for all this process, the starting point is you. If you notify, the process will go on. If you don't notify, we will not get the very fruitful, very important information from the hospitals. And the community people, our community health staff, the public health staff will not get enough information from the patients in their community. So you are doing a very important part of this notification because you are the starting point. From you, what you're supposed to do is, if you come across with any patient with a notifiable disease, please fill that H5444. And the nursing officer will fill that notification register, and from that she will send to the ICNO. From that she will send it to the MOH office. They will investigate, and they will send the weekly return to the epidemiology. So we will get a summary of the communicable diseases we had in that particular week. And to complete this surveillance, we have to give a feedback, right? So for feedback, so we publish weekly epidemiological reports. Weekly we publish with this information, quarterly epidemiology bulletin and annual health bulletin, right? And also that what I mentioned, that weekly return of WRCD, weekly return of communicable diseases, we return from each and every MOH office is a web-based. So very easily, with a very few minutes, we can get a summary of it, right? So make sure and remember that you are doing an important part by notifying all these notifiable cases, right? So action at the MOH office, at the PHI. So this shows the importance of notification action during the field investigation by PHI. So now I mentioned that PHI is supposed to go and investigate, confirm the diagnosis. He has to identify whether the address is correct, patient is there, the diagnosis is correct. Ensure the patient is taking proper treatment and encourage continuous treatment. By that time, if you take is a dengue patient, TB patient, the PHI is supposed to check whether that patient is taking proper treatment or not. Assess the health of the contact person. So there are contact person, if they haven't symptoms, the PHI can refer the patients to a nearby hospital. Observe the environment to locate the potential source of infection. If the notified case is a dengue case, lepto case, so the PHI can do preventive measures for the environment. Take control measures to prevent further spread in the disease. So that's what he is doing. Take measures to ensure the prevention of future outbreak spread. So he can program, he can have community cleaning programs, the environmental cleaning programs, and also health education, right? So everything happen only if they get the notification. Notification procedure, I mentioned to you, notification of communicable disease using H5 form. That's what you are doing to the relevant MOH data. That is the most important part, right? So other than that, right, there's a special notification or the special surveillance for some selected diseases. The reason is, with this WRCD, weekly return of communicable diseases, we get only the numbers from the MOH office. How many dengue patients are there? How many lepto patients are there? How many measles cases are there? How many mumps cases are there? But for the surveillance purposes, for the epidemiology, we need some little bit more information. Because of that, for some special diseases, we have introduced special notification from the hospitals and the community. So for some diseases, poliomyelitis, all the vaccine preventable diseases, we have special surveillance. And with some other diseases, international concern, like cholera, plague, yellow fever, avian influenza, Ebola, and lepto. Also we have, and rabies, we have special investigation, right? So this special investigation of vaccine preventable diseases will be done by some other consultants in the evening, right? So you will get that information. For the time being, please remember your main purpose, your main objective, and the main thing that we expect from you is to fill that H544 form for each and every if you come across any patient with a notifiable disease, right? Why communicable disease surveillance is necessary? Why this is necessary? Because it's determining the burden of the disease. So by the end of the week, by Friday, we can get the disease epidemiology of the country to monitor the disease trend, time to time, how the diseases are changing. So we can take a analysis of this disease information. Detect and predict outbreaks early, timely, appropriate measures. We can take appropriate measures. So it's a good purpose to identify the outbreak, though it is a passive type of a surveillance system, but it is intact and it's linked with our event-based surveillance. Even though with this passive surveillance, if there are high number of cases from the hospital, the ICNOs and the MOHs, they are usually, they contact us and they inform us, so we do timely action. So this surveillance system support us to do to prevent outbreaks, right? Identify high-risk population and areas requesting special attention. Right? After surveying and analyzing this data, we can identify high-risk population. Monitor impact and progress of preventive strategies we can monitor. Identify areas poor performance for corrective measures. Rational health planning and resource allocation basis for epidemiological risk. So this everything, the every purpose and the importance we get only if you notify. Right? So at last, the last slide. Common mistakes done by interns in notification process. So we expect only to fill the H5444. Not notify on suspicion of communicable disease. So you don't need to worry. As I am repeatedly saying, don't wait until you get the confirmation. We are not expecting that. Should not wait till confirmation or at the time of discharge. Purpose is prevention. On suspicion, you notify. That's all right. Don't worry whether the diagnosis is correct or not. That's all right, but please notify. Incomplete notification form. So poor quality, not all. There are some notification forms. The address is incorrect. The contact number, it may be not your fault. Please make sure to write the address very clearly and the patient name, age, and other information. Right? And if available, please add the lab results as well. Right? Incorrect address in H544 should not take from the VHD. Need to ask the patients and write. So that is very important. Please don't get the address from the VHD or from the admission register. Please take the address from the patient's history. Late notification of suspected cases, please notify at your earliest. So that will do a very much support to prevent further spread of the disease. Okay, thank you.
Right. Thank you very much, Dr. Chandra Pereira, on that detailed lecture on communicable disease and surveillance and disease notification. So if you all have questions, we can use the chat box. So at the meantime, next lecture is by Dr. Pubudu Chulasiri on consultant community physician at anti-malaria campaign on malaria control. Over to you, Dr.
Yeah, can you give me the access to the presentation chart? I can't upload the document from here.
I'm sorry?
I can't upload. Yes, okay. Now I can do it. Okay. Can you see the presentation now? Hello?
Yes.
Hey, yeah.
We'll make it full screen and we'll move few slides and see.
Okay.
Yes. You can start.
Okay. Good morning. I am Dr. Subhadip Chudasiri, consultant community physician from the anti-malaria campaign. Good morning, all of you. As intern officers, I think you have to know many diseases, especially the communicable diseases. So out of that, you may not be well aware on malaria, because one thing is malaria is no more present in Sri Lanka. It's an eliminated disease. Other thing is usually it's a forgotten disease. As malaria is eliminated, it's a forgotten disease. So usually as you are undergraduate, you might have not had any malaria case in your undergraduate period. So that's why it usually gets forgotten. So because of this forgotten issue, usually not considering as an important case, we had some few cases. I will just brief you now. We had some few cases. That's mainly the negligence of our healthcare personnel caused them to have the disease and even the death. This case actually happened in 2020. He was a person, 31-year person, went to Uganda, and he just came to Sri Lanka after working there 1 year. He just came to Sri Lanka. Sorry. He just came to Sri Lanka. And after that, he was feeling a little bit unwell. And he just contacted his doctor, first contact doctor, within 4 days. But unfortunately, after contacting the first doctor, it took 46 days to diagnose that patient is having malaria, because there is a clear travel history, and he had contacted 2 GPs and 2 consultants even. But unfortunately, no one suspected that patient may be having malaria. And only the patient himself just talked to our campaign and asked that he's been admitted to the hospital, but he was not tested for malaria. Then only we just asked the hospital to check for malaria, and he was positive. So 46 days, he was in the field with the malaria parasite inside the body. Severe medical negligence from our side. So actually, this would have prevented that whenever person come with a fever itself and ask the travel history, sometimes mostly they say that they have been to malaria endemic country. I will tell you what are the countries later. So then, unless proven otherwise, if someone is having fever, and if someone is having fever and a travel history to a malaria endemic country for last 1 year, and it should be malaria unless proven otherwise. So this is the first case. And the second case also, army technician, okay, went to peacekeeping mission, and actually he just went there and stayed there and came to Sri Lanka, and he had fever, chills and dry ghost. But within 2 years, he was admitted to the army hospital. But unfortunately, they suspected that patient having dengue. And 2 times he was discharged from the hospital thinking that dengue, because dengue was negative, and he was discharged. But later only, seen by a consultant in Gampa, then the consultant suspected that patient may be having malaria and checked for malaria, and it took 14 days for him to be diagnosed as a malaria patient. So whose fault is that? Yes, it's a mainly. He came within 2 days, but it took 14 days him to be diagnosed. And the third case, a Lebanese, came to Sri Lanka actually for his honeymoon, and after coming within 1 day he got fever, excuse me. Yeah, 1 day, and after the illness, he just had PCM, some treatment by himself. But after the contacting of the first contact healthcare person, he was asked to be diagnosed as malaria patient. And when we did the investigation, its count was more than 500,000. But within hours, we just started the treatment, and after later, his next day, his count was less than 1,000. We saved that patient. Why I am saying that we saved? There was another patient in 2023. Same, he went to Tanzania, and he came here, and he just stayed in the. He was treated by several doctors for 5 days, but he came severe, and he was admitted to the ICU, and he died. His count was 839,000, almost same to that this patient. But he, even only after the death, we were informed, and he was not given any treatment, unfortunately, for the malaria. If he had been given the treatment, he would have saved. So by these 4 cases, what we can see that if we identify the patient earlier, a malaria patient early, there is a very, very, very efficient treatment, and we can save lives. The main thing is we have to suspect and treat the patient. Based on that, I am coming for some background of malaria. We all know that malaria is caused by a parasite. There are 4 parasites responsible for malaria, but usually we get Plasmodium falciparum, Plasmodium vivax cases, and there are mosquitoes in Sri Lanka who are responsible for the spreading of malaria. So Anopheles erythropathy is the primary main vector, and there are other malaria vectors as well. So you can see that, yes, if we had Plasmodium falciparum, usually they present to us within 50 days because they don't have any hypnocytes. But if they infected with Plasmodium vivax ovale, sometimes it takes around 1 year to have symptoms. That is the issue. Sometimes patient also not remember that even they had been to any malaria endemic country. That is the issue. Sometimes they may not declare malaria, the travel history. So that's why it's very important as house officers, interns, we have to just ask more on their travel history when they are having fever and suspected of traveling to a malaria endemic country. As I said earlier, usually 25 patients have been diagnosed more than 7 days of their symptoms. That is the main issue. So here, this is the total history of malaria. You can see that there were several ups and downs, and after that we had almost eliminated malaria in 1963, but there were some issues, some force done by some government of that era, and then it lasted malaria for 40 years, and in 2012, actually, 2012, we got last 23 malaria cases. You can see that in 1999, almost all country had indigenous malaria cases, and 2012, within 13 years, we could achieve almost 0 cases. And from 2003, we don't have any indigenous malaria cases. Indigenous means the person getting malaria from this country. So we had last death in 2007. After that only, unfortunately, we had the malaria death in 2023. And Sri Lanka was certified as malaria eliminated country in 2016. So other than Sri Lanka, Singapore and the Maldives are the only countries in Southeast Asian region where the malaria-free certificate has been given. So many countries were still having malaria, especially in the African region, Southeast Asian region, and the South American region. So as anti-malaria campaign, our main goals and objectives are, main goal is to maintain malaria-free status, and the objective is to prevent reintroduction. That means we had malaria, but we eliminate malaria, then we cannot have any reintroduced case. Reintroduced case means a person in Sri Lanka getting malaria parasite from my imported cases. So we always try to prevent this reintroduced case. But sometimes we may fail, but our main objective is to prevent reintroduction and maintain the zero mortality. To maintain the zero mortality, the prompt diagnosis and the prompt treatment are the major strategies that we have to keep in mind. As I said earlier, look, we can see that almost all countries in the equator, near the equator, are having malaria except Sri Lanka. So yes, so usually even though we eliminated malaria in 2012, we got certification in 2016. Even before that, we are getting, as I said, imported malaria cases. Usually around 40 to 50 malaria cases are being reported in each year. And also this year, so far, we got 46 imported malaria cases. And most of the malaria, almost all the malaria cases have been reported from the people who have traveled in African region. Earlier, before COVID, many people got malaria because of their travel to India for the pilgrimage. But as the pilgrimage is not there much, usually now we get the malaria cases from African region. So what you have to do is, whenever you get a patient with fever, and if you suspect they might have travel history, ask whether they have been to an African region, okay, for last 1 year. If they had been to a malaria endemic country for last 1 year, you have to suspect malaria and ask for the diagnosis. Usually, as I said earlier, because of most of people are coming from African region, now most of 75 cases are being reported as Plasmodium falciparum cases. The issue of the Plasmodium falciparum case is it can be lethal. Sometimes the Plasmodium falciparum get complication and as well as death. So that is the issue that we are facing now. So as I said earlier, these are the malaria endemic country. In each year, the World Health Organization just publish the countries where the malaria is endemic. So this is, we have given some leaflets, and you can keep this presentation with you as well to see whether these countries are malaria endemic or not, or you can visit our website and see whether this country is endemic. But usually, most of the African countries and the South American countries and almost all the Southeast Asian region are endemic for malaria. So what are the risk groups? So whenever you get a patient, because they are at risk, mostly people are at risk. Who are these risk groups? There are two groups. One thing is Sri Lankans who have traveled to either Africa or the South America or Southeast Asian region. They are at risk. And the other groups is the people who are working, who are living there in foreign countries, and especially endemic country has come to Sri Lanka. They are the next group. So who are these risk group? One thing is Triforces. Usually the Triforces, they go for the South Sudan and Mali for their peacekeeping mission. They go there, and after working there for 1 year, they return to Sri Lanka. So usually in each year, around 4 to 5 cases are being reported as malaria cases. So whenever you get a Triforces person with fever, okay, just ask whether they have gone for the peacekeeping mission. Sometimes they might not remember that they have been, sometimes they might not declare. So you have to ask that whether he has been to malaria endemic country within last year. The next one thing is the gem traders. Usually people who are working, who are in Berual area, Alutgam area, Balangoda, Gol, and Aliagoda, and Matale. These people, usually some gem business people, go to either Mozambique, Madagascar, Tanzania for the gem business. So after returning, usually sometimes they come with fever and not declare that they have been to a malaria endemic country. So gem traders are the major issue, because most of them do not take prophylaxis as well. So if you are working in these areas, especially in these hospitals, you have to make sure that you just ask the travel history from them. And the migrant worker who are returning from malaria endemic country, because there are many people who are working in African region in garment factories and other factories, and they work there and come to Sri Lanka, and sometimes they present with malaria patient. And pilgrims to India and Myanmar, usually they go there and come here. The issue is pilgrims visited to India, usually, as I said earlier, usually they present with fever even after 10 months or 11 months. So that's why you have to ask more travel history if you can't diagnose any other disease. So tourists who travel to malaria returnees, those are the Sri Lankans. And foreigners, foreign workers, tourists from other countries. Usually tourists come to African region and then come to Sri Lanka, and they get infected from this African region and present as malaria patient. And migrant workers returning from malaria endemic country, especially the asylum seekers. You usually, in 1 or 2 cases we get in each year, asylum seekers, they are staying in certain places in Sri Lanka, especially in Negombo area, Kalutara, and yes, mainly those areas, they stay there, and they present it as malaria patient and the illegal migrant, especially the fishermen, especially the Indian citizens. So what is the role of intern house officer? You know that, yeah, if someone presents with fever, you have to ask the travel history. Yeah. The first is always suspect malaria. You have to suspect malaria. Whenever someone develops fever within 1 year of return from malaria endemic country, yes, you have to suspect that he may be having malaria. So major clinical features, earlier we were told that typical chills and rigors, high fever, These are the features, but classical, these features are rarely seen. Now we don't see many things. Many these high fever and chills and trigo. Sometimes they present only with headache, mild fever, body aches, chills and trigo. Sometimes they present with chill and trigo, dry cough. So usually don't wait to have this the classical features of malaria. But the important thing is, as I said earlier repeatedly, the asking travel history. So whenever you suspect malaria, yes, you have to inform the regional malaria officer because malaria is a notifiable disease. Why do we need to inform regional malaria officer and anti-malaria campaign? Because we need to confirm the diagnosis, and almost all the drugs are with the anti-malaria campaign, and we have to provide these drugs. And the other thing is, most of the doctors, the treating physicians, they are not well aware about the treatment, dosage, and frequency of malaria drugs. So we have to provide drugs. That's why if you suspect malaria patient, please notify immediate to the regional malaria officer and the anti-malaria campaign. I will give you the anti-malaria campaign hotline number later. So because if you diagnose at the OPD, all patients should be admitted to a hospital where the consultant physician is there, and he should be treated under the LLIN bed net. So second thing is how to diagnose, when to diagnose, when to test for malaria. If you suspect malaria, you have to do microscopy. So if as you are working in the base hospital and above where the consultants are there are PHLDs in each hospital. They are well competent to diagnose malaria. So you have to inform the laboratory to do the microscopy. Microscopy is must, because other than microscopy, there are rapid diagnostic tests we can do to identify malaria, but those are not confirmatory tests. Microscopy is the confirmatory test. Microscopy means thick and thin blood smear. So microscopy is mandatory. And the other thing is, if it is negative for first day, you cannot exclude malaria. You have to do 3 consecutive days. Today he may be negative, but tomorrow it will be positive. So unless you do the 3 consecutive days, you cannot say that patient is negative. DT, usually it's the person's the PHLTs or public health field officer working in the hospital. They come to the ward and do the RDT. It's a test that you can do very easily, and you can get the results within 20 minutes. And these are highly sensitive tests. So, but RDT is not confirmatory. The microscopy is the confirmatory test. Unless you do the microscopy, you can't treat the patient. You can treat the patient only when the microscopy is ready. So as you know, there are 2 blood cells, thick smear and thin smear. So by doing that, you can identify the species, stages, and the counts as well. So whenever do screening them, even before they come to the hospital, sometimes we do screening at the field. So after screening the patient, we give her the screening card. So if a patient has been screened earlier, he may be having that card. So please, whenever they say that I have been screened earlier,